Our next speaker is Dr. Jeff Bazarian, who is going to speak on advanced imaging. He's an emergency medicine physician and director of the University of Rochester Sports Concussion Clinic. He has served on several TBI-related task forces and panels for the CDC, the National Institutes of Health, the National Science Foundation, and the Institute of Medicine. Please join me in welcoming Dr. Jeff Bazarian.
Yeah, it's always difficult to follow Julian Bales. So I'm from the University of Rochester. It's not exactly a football powerhouse. Colors are similar to University of Michigan. That's probably where the football analogies end. But every one of the athletes there is totally into us doing research on them, and we've been able to say a lot about imaging and biomarkers, especially blood tests, because of their participation. So I'm proud to be from there, even though it's a D3 school and everyone's got a lot of heart. So I want to spend just a few minutes talking about not only imaging, but also blood tests that could potentially make your job a little easier. And these are my disclosures. Okay, so as has been said multiple times, trying to figure out from the sideline whether someone's been concussed ain't easy. And I'm an ER doc, but I also spend a lot of time on the sidelines doing research. And Scott Anderson and I were talking about this. It's hard. It's really hard. Unless they're like totally knocked out, it's pretty hard to do. And you guys have a really tough job. And you got the scat, you got things to help. But at the end of the day, this is really a difficult call. So is there something more objective that maybe we can inject into what you're doing to make your job easier? So I want to spend a few minutes today talking about what the potential role of neuroimaging and serum brain proteins would be. Now, normally each one of those topics could occupy an hour-long talk. So we're going to get a 30,000-foot view of this, and I'm going to focus pretty much on diffusion tensor imaging and a few brain proteins. So I guess from where I stand, the potential will be on the sideline maybe to have some kind of finger stick test or some kind of test where you'd prick someone's earlobe maybe to help you figure out whether they had a concussion. Imaging on the sidelines, a tough sell. I mean, there are portable MRIs like this van thing, but I don't see one of those, even at the University of Michigan. In the clinic or in the ED, imaging might be a little more practical to help make a diagnosis, but that doesn't help you folks who are involved in athletic training. It would help Chris Giza, but I think he already can do it without an MRI. That's what he told me last night anyway. Okay, so let's start with blood. So how is it that stuff in the blood can help us figure out whether someone had brain injury? So as Blaine told you, the main problem for the head is that it rests on the neck, and whether it gets struck or whether it just rapidly decelerates, it swings. It's kind of like the bobblehead phenomenon. And that rotational movement, that rotational acceleration is a problem for the brain because it's made up of these cells that are super long spaghetti strands. And that rotation is enough to just stretch them. So because of the architecture of the cells in the brain, this rotation is a problem. So neurons, which are the main cells of the brain, stretch with head rotation. And when they stretch, you get the Chris Giza neurometabolic cascade. All kinds of stuff goes out of whack with the neuron. And then the process of it going out of whack, it releases proteins. And if the blood-brain barrier is open, those proteins can find their way into the blood where we can detect them. So there's a couple of conditions that have to be met. You gotta stretch it enough, blood-brain barrier's gotta be open. And it's not just the neuron that's a problem here, it's also the astrocyte. And I'm so happy that, Julian, you teed that up for me because astrocyte is another cell type that's super important for the brain to work. It's not the cell that transmits an impulse, but it's like the mother bear cell. It takes care of the neuron. If the astrocyte ain't happy, the neuron ain't happy. So that astrocyte also gets damaged and can release proteins into the blood as well. So we're often looking at proteins not just from neurons, but from astrocytes. And astrocytes are like right up next to the blood vessels. So often they're the first proteins that get into the blood. So the idea is you get some damage, we pick it up in the blood, and then we can maybe say whether you had brain injury or not. Sounds like a pretty simple idea, right? Not so simple. So before I get into telling you why this is not so simple, I guess it's incumbent on me to tell you that pretty much nobody recommends that you do blood testing like anywhere, anytime in the setting of sport concussion. So the Berlin folks said fluid biomarkers are important research tools, but require further validation. Okay, really? And then there was an Institute of Medicine report that kind of said the same thing. There was no evidence for the use to diagnose concussion, but there might be some evidence for its use to figure out who needs a CT scan, which I think Dr. Giza brought up earlier, and I'll touch on in a minute. Yeah, so all your professional organizations right now are saying no, but I think this is coming, so I'm hoping you'll be interested in the rest of these slides. So before I can talk about the rest of these slides, I have to just make sure everybody's on board with sensitivity and specificity, and I apologize for those of you who already know about this. But these are kind of two ways to tell how accurate a test is. Sensitivity kind of is connected to negative predictive values, so highly sensitive tests are good at ruling stuff out, and specificity is kind of connected to positive predictive values, so highly specific tests are good at ruling things in. Now, there's a way to combine both of those measures, and that's what's over on the right. And if you kind of combine them into like a global accuracy measure, that's called a area under the receiver operating characteristic curve, or just AUC. And like the best test in the world has an AUC of 1, which means it's like perfect. But there ain't no such test out there. So I put down here an example of a test that we use quite commonly down on the lower right. It's called a D-dimer protein. We use it in emergency all the time to figure out whether someone's had a blood clot to their lung. So chest pain, get this test, helps us figure it out. So that's a really commonly used test, has an AUC of 0.86. So that kind of gives you like a ballpark of, what's a realistic accuracy measure, because I'm about to show you some accuracy measures for brain proteins. So if you kind of keep 0.86 in your mind, that's a kind of a reference. All right, so here's the money slide. This is like a summary of all of the studies that have looked at brain proteins to classify, to diagnose concussion, to say you either are concussed or you're not concussed. And what we have is their AUCs, their overall global accuracy on the vertical axis, and on the horizontal axis is the time that the blood was taken. So, there are lots of studies that were 1 hour, 3 hours, 6 hours, and then studies all the way out to 1 month, 3 months, and greater than 3 months. So that dotted line through the middle there, that's like an absolutely worthless test, and that kind of gray line across the top, that's the 0.86. That's kind of where the D-dimer, that's like a good test level. And you can see that some of these brain proteins they're close. They're close to kind of where they would be useful in classifying someone as being concussed or not concussed. And the ones that tend to be the best are interestingly enough, tau. And you just heard from Dr. Bales that tau is the protein implicated in the phosphorylated form anyway, in CTE. So here we are picking it up in the blood after concussion, and at multiple time points. What's interesting is that there are no data for proteins measured in that first hour after injury. And that's what we really need, right? That's when you guys are going to be making these decisions, not at 3, 6, 8 hours later. We need to know how good are these proteins in minutes after a hit. So there's no data there, but there are lots of people, including myself, trying to fill in that gap. But I think this slide kind of points out the potential maybe for blood tests to classify subjects as being concussed or not concussed. Just as a proof of principle, the brain proteins are already in use, and I think Chris also mentioned this, thanks a lot for pretty much giving away most of my talk, is already in use in multiple countries in Europe, not to diagnose concussion, but to figure out who needs a CT scan. And about 5 to 10% of concussed patients have some bleeding in their brain. They need a CT scan. Some of them need surgery. And it's S100B is the protein that they use. And in fact, the FDA just recently approved 2 brain proteins for that use in the United States, not for diagnosing concussion, but for figuring out who needs a CT scan. I was the first author on that paper. It was a multi-centered trial. And Chris is also correct that it's not available quite yet because the companies are trying to figure out how to get these into ED settings, which is where it'll probably show up first. So there's going to be brain proteins out there to help you decide who needs a CT scan, but not to help you decide who's concussed or not concussed yet. But I think that the future would be something like this, some kind of a point-of-care test device, and both Abbott and I'm going to really butcher this name, Biomarkers, it's a French company, have a point-of-care test devices where they're putting GFAP and UCHL1 on the platform so that this could potentially be done anywhere, anytime. So if we can work out the logistics of do they separate concussed from non-concussed, this could be coming to you at some point in the future. Okay, now I'm going to switch to neuroimaging, and I'm only going to talk about diffusion tensor imaging because it's the most robust kind of advanced neuroimaging modality out there. But here's the kicker. What I just told you about brain biomarkers, those are good for classifying people as concussed. And I think we've heard several talks already about how lousy the clinical definition or how inconsistent and variable it is. Like, how do we know when someone's concussed? When they tell us, we use a scat. So we basically have a blood test that tells us, oh yeah, we can predict this kind of crummy, mushy clinical definition, but I don't know if that's what we want. I think we want a blood test that tells us if we have brain injury, not whether it kind of correlates with this mushy kind of clinical definition. And I think Matt brought that up pretty nicely in his talk. So I think the FDA's strategy is going to be in order to have a test that diagnoses concussion, they're not going to want to see a group of people with clinically diagnosed concussion. They're going to want some neuroimaging evidence of brain injury. Well, we can't do autopsy. We can't take a brain sample from somebody. So this is the closest gold standard that I think we're going to get is diffusion tensor imaging with some way of visualizing axonal injury and saying, okay, that's our reference standard. Now let's match up these blood tests against that reference standard and see how well it works. So this is what's tricky about getting the biomarker to the next step is it involves really flushing out DTI first, and then doing studies where we're getting blood within that first hour. So let me tell you a little bit about DTI, and then you can decide how long it's going to take for us to get to where we need to be. So by the way, no one thinks you should be doing MRI or DTI. There's no recommendation that says you should be doing that. So this is like a researchy kind of thing, not a clinical care thing. Okay, so what is DTI looking at? It's pretty much looking at the structural changes that happen to the axon, Chris Giese's neurometabolic cascade. You can see that that's it. That's your figure right there in the upper left, right, Chris? Yeah, okay, just want to. So in the middle of that tube there, that axon is that bulb, that swelling. So that swelling is what DTI picks up. When the axon swells, it actually changes how water moves in the brain, and DTI is looking at water movement. So we're not picking up any of the other crazy stuff that Dr. Giese worked out. It's that structural change to the axon that we're picking up. So you get swelling, and then the axon dies and goes away. And so DTI sees those events. That's what it's not really anything more complicated than that. DTI has 2 ways of looking at water movement, kind of like how much water is moving in between those axons and how straight is it moving. And both of those things are changed when an axon swells up and then when it disconnects and goes away. So perfect. We have a test that kind of can pick up the events that go along with brain injury. And so the pros of this test, out of all the imaging tests that are out there, is there's a lot of good data relating to animal studies, where they whack an animal on the brain, they look at it under the microscope, and then they actually image the brain with DTI, and they go, oh, that lines right up, that's perfect. There's been a lot of human studies out there, that's also good, and it is a reasonable classifier. It actually is good at separating concussed from non-concussed. It's a little more sensitive than specific, and I'll tell you about that in a second. But what's interesting with all of these biomarkers is the more we look, the more things we find. It looks like we start to see brain injury when people have subconcussive head hits, not just concussion, but when they hit their head and don't have any symptoms or signs of concussion. Uh-oh. So that kind of screws up what we're trying to do here, right? How do we know are we waiting for people to come and say to us, my head hurts? Maybe they're having brain injury, all the time. There's at least 3 groups that have shown the amount of injury on a DTI scan in football players that are asymptomatic is directly related to helmet accelerometer measured head hits during the course of the season. So that suggests there's some kind of dose-response relationship between getting hit on the head and having what looks like brain injury on these scans. So that's kind of a running theme with biomarkers is the more we look, the more the line between concussed and non-concussed kind of blurs, which certainly doesn't make your job any easier, nor Chris Gies's for that matter. Here's the data showing that DTI pretty much picks up injury in animal studies. We can't do this kind of thing in humans, but we can do it in animals, and it picks up axonal swelling and then disconnection. And the idea is when you get axonal swelling, the water is kind of squished, has to move more straight. And then when you get axonal loss, it can kind of freely float. And the DTI can see both of those events. Where are most of the abnormalities that we see? Red is, this is kind of like a summary of all the DTI studies in humans. And red is like where most of the studies found abnormalities, so the frontal part of the brain. The interesting thing is probably the neural signature, the area that's commonly injured no matter where you get hit is the midbrain. And there are only a few studies that have shown that. But Julian had a really nice cartoon where you could see no matter where the head gets hit and rotates, the focal point is really down there at the base of the skull in the midbrain. So no matter where the head gets hit, it's those white matter tracks running right through the midbrain that get injured. And we have a paper coming out in Science Advances that shows that section gets injured whether you're concussed or whether you just played football for a season and didn't get concussed. So subconcussion and concussion both have injury to the midbrain. And it just so happens that all of the things that go awry in concussed patients are midbrain functions. Vestibular, sleep, accommodation, convergence, those are all structures that are controlled, they're functions that are controlled by structures in the midbrain. So I have a feeling that's where we're going to be looking in the future, is just focusing right there, forget about the rest of the brain. That would really be kind of nice. So that's where the action is. All right, so yeah, great. DTI is the best thing since sliced bread, right? Well, not really. So it has some issues that are making it difficult to tweak and to get it to the point where we can use it to validate brain proteins. It's quantitative, number one. You get like 100,000 numbers for each scan, and you got to figure out what to do with them. So it's not like a chest X-ray where you go, oh, yeah, there's the pneumothorax right there. No, you get like 100,000 numbers, and you have to figure out, are they normal? Are they not normal? Where are they not normal? So it's a little cumbersome to work with. The other problem is TBI, really heterogeneous problem. If you get hit in the head, you may have injury in one place. You get hit in the head, you have it in another place. When we try to do group analyses, they kind of average out. It looks like there's nothing wrong. So we have to have a way to analyze everybody's brain individually to kind of overcome that problem, and that's problematic. And what we really need is a ton of normative data. We need DTI scans on like you guys, so that I could take an injured person and put it up against a pooled normal group and say, okay, yeah, that's where the injury is. And that work hasn't been done. It's very similar to the CTE issue. There's a problem with crossing fibers. There are other methodologic issues that have made this a little bit difficult to work with. I think they can be overcome, but they haven't been overcome at this point in time. And here are just a sampling of the studies that show after a concussion where you get injury. Most of the time the injury is in the corpus callosum, which is kind of like silly because that's just where most of the neurons are all kind of clumped together there. So of course you're more likely to find, like finding your car keys under the street light. That's because the light's shining on it. So most studies find that injury in a corpus callosum is not very helpful because that's just kind of where most of the axons all kind of group together. But they're remarkably similar in terms of the direction of change and how they resolve over time. And this is just a slide to say, okay, there are problems with DTI, but we can overcome them. There's ways to get through some of the technical limitations of this scan, and it's still not really used real time. It's used real time for some things, but not for TBI. So it's got a little bit of a ways to go, but I think the FDA is going to be looking to this imaging modality to be the reference standard for a biomarker that says you have brain injury. I guess concussion would probably be the wrong word. You have brain injury versus you don't have brain injury. Okay, I think, so just to kind of sum up, this is a big challenge for using biomarkers, using neuroimaging or blood tests to figure out whether someone's got brain injury or not, is we have to deal with, is this a concussion or do I have an abnormal blood test here because you just hit your head 40 times? I mean, is this a concussion or just, subconcussive head hits? To make matters even more complicated, some of these brain proteins show up in the blood just with body impacts and even just aerobic exertion. You can have people just run, and some of these brain proteins will be elevated in the blood. So that's kind of interesting. Here's a couple studies that show that. You can get S100B elevated in swimming, cycling, Greco-Roman style wrestling. Chris, I think that's something you said you did at Dartmouth, I think. And also sorry, I'm not gonna, I had to do that. And you also can get it with the subconcussive head impact. So people have found both S100B and tau going up after a sporting contest without concussion. And we looked at this in some of our D3 U of R football players. We ran them for 30 minutes and we did the finger stick blood on them right before they ran. And after the 30-minute run, we did it at like 15 minutes, 30 minutes, 45, and 60. And you can see like it went up a little bit with running, went up like 15 minutes, 30 minutes, and then by 60 minutes was starting to come back down. So just running elevated their tau, and it took almost an hour for it to kind of wash out. We did something similar with a contact practice where nobody was getting concussed, and the people that were most likely to get some high impact hits had some of the biggest elevations in tau. So these are things we have to think about and account for if we're going to use a blood test on the sideline. And it's not that it can't be done, it's just that we have to figure out how to do it and implement it. And I think these could be really powerful tools for helping you guys do your job better. And honestly, that would probably help the people on the receiving end, the docs that have to see them down the line on their end as well. Okay, so just to kind of put a bow on this, so serum brain proteins hold promise for kind of classifying people with clinically defined concussion across a range of time points. We don't have any data from that golden first hour. And again, if we're going to use it to diagnose brain injury, which I guess I'd argue that's what we really want to know, we really need to develop DTI as a gold standard. And DTI's got some technical issues that need to be worked out, but I think they can be worked out and will be worked out and will serve as probably a reference standard for moving this forward. So, I mean, if you can be involved in helping with this, if somebody asks you to be involved doing it, I think it would be great, because Michigan is a great research institution. To the extent that you could help with this effort would be fantastic. And I thank you for your time.